So again, I'm really excited to be here, and I am joining you from Vancouver, so the territory of the Salish, Tsleil-Waututh, and Musqueam people, and I'd like to extend my appreciation to their elders, past, present, and emerging. This work was actually done while I was doing my postdoc at both Simon Fraser and the Westmead Applied Research Centre in Sydney, Australia. And I just want to give you an overview of the presentation component. We will have plenty of time for what I hope will be a spirited and lively conversation at the end. This presentation part will probably last for roughly 30 minutes. And I know that the Zoom format means that people come from a lot of different places geographically, but it also means that people come from a lot of different backgrounds. So I'm going to start by giving kind of a broad overview of what we mean when we talk about healthy aging, and then some of what we know about the environmental supports that are important for achieving healthy aging across populations. Next, I'll describe the World Health Organization's Age-Friendly Cities, or AFC framework, in a fair amount of detail because it's really important to this field of research and particularly critical for communities, planners, policymakers who really want to help ensure that their communities support that healthy aging process. Now that framework does have some critiques, so I'll also talk about some other audit tools that have been developed in response to it for application to a more diverse range of settings, including rural communities. Next, I'm going to talk about an audit tool that we actually developed within the context of the Prospective Urban and Rural Epidemiology study to really examine healthy aging in communities around the globe. And I'll tell you a bit about what we found in terms of that global variation in access to healthy aging supports. Next, I'm going to really focus on what we know about the range of environmental influences on social ties, particularly important in this pandemic era. And then finally, the way that we can integrate age-friendly designs into these kind of broader constructs, such as healthy cities. So one of the reasons that my research has begun to focus on older adults is because their population is growing rapidly. In fact, the number of individuals aged 60 and over is expected to more than double from 1 billion in 2018 to more than 2.1 billion by 2050. At the same time, the globe's population is urbanizing, and that urban population is projected to increase by nearly 60% to a total of 6.7 billion inhabitants over the same time frame. And it's important to note that even though these trends are occurring worldwide, that process really isn't taking place at the same rate in all countries. In fact, the proportion of adults aged over 65 in low and middle income countries, or LMIC, is growing 3.5 times faster than it is in high income countries. And those dual trends of aging and urbanization present some challenges, particularly in low and middle income countries that can often have fewer resources. But it also represents an opportunity, because it means that we can identify what environmental features are really critical to healthy aging and then ensure that they're integrated into newly urbanized environments. So in response to these dramatic changes in both urbanization and aging, the World Health Organization actually declared the current decade of 2021 to 2030 to be the decade of healthy aging. And they really did that because they wanted to advance intersectoral collaboration between people like myself who work in the field of public health and people who work in fields such as urban planning. And I think it's important to really understand what we mean when we talk about healthy aging, because that can mean different things to different people. So I think it's really helpful to look at how the World Health Organization defines healthy aging. And their definition acknowledges that individuals may have one or more chronic health conditions at this stage of life. So the goal is really to maintain optimal functioning. So not necessarily perfect functioning, but how people can continue to thrive. And this may, of course, look different across an individual's lifespan. For example, even though a condition such as arthritis may make an older person a bit slower on the tennis court, healthy aging means that person is still able to participate in the sport they enjoy. And more broadly, any chronic conditions should only minimally restrict core activities, things such as cognition, mobility, and social participation. I also think that the WHO's focus on collaboration acknowledges that we really need to broaden our lens of healthy aging beyond a clinical focus. So of course, it's important for people to have access to the medications and physical therapy that may help treat their arthritis. But it's equally important to create built, natural, social, and economic environments that allow them to live as healthfully as possible. So acknowledging this interrelationship between individual capacities and influencing environments is embedded in that age-friendly cities framework. And this was really one of the first developments to spur research in this particular area and for this particular age group. And both the initial framework and the subsequent indicators were developed to clarify exactly what aspects of local environments are most important to healthy aging and how we can translate what we know from public health to urban design. The framework was initially developed in 2007, and they did that by carrying out focus groups with older adults, their caregivers, and service providers in 33 cities. But they found that that really didn't quite meet that translational need. So the World Health Organization carried out a more expansive process from 2012 to 2015, and that integrated literature reviews, 2 expert consultation meetings, several rounds of peer review, and a pilot study applying their draft indicators in 40 communities across 15 nations. And it's really important to note that that process was guided by 3 principles: advancing equity, ensuring accessibility of physical environments, and achieving inclusive social environments. Now, I'm going to talk a bit more at the end of my presentation about issues of equity, but it's really those final 2 principles that were the focus of my own recent research and many of the other assessment tools that I'll describe. So building off of those guiding principles, the World Health Organization delineated a number of broad domains and then detailed precisely how communities can assess age friendliness within each individual domain. And one aspect of their recommendations that I think is especially important is that they really offer 2 different paths to measurement that are distinct but complementary. So one set of objective indicators and one set of subjective indicators. Just to take one domain, the domain of transportation, for instance, communities who have access to administrative data from, say, a planning department or a transit authority can use that to calculate the proportion of residences within 500 meters of a public transit stop. Alternately, a survey of older adult residents can be used to determine the percent of this age group who report that public transit stops are accessible. Now, unfortunately, even with this flexibility in terms of data sources and indicator definitions, the AFC indicators have proven challenging to implement, and that's particularly true in low and middle income countries and in rural settings. In fact, an attempt to apply the core indicators to a population-based study of adults 60 and over across China challenged them as being heavily urban-oriented and industrial-centric. And similar concerns have been raised by a number of other researchers and practitioners, including a study in Nairobi, Kenya, that sought to understand the challenges faced by older adults residing in informal settlements, what many people previously called slums. The focus on cities rather than communities more broadly has also led to issues with applying the framework in rural areas. For instance, the Canadian Agefriendly Rural and Remote Communities Initiative conducted focus groups in 10 rural communities to really understand how the AFC framework might apply to rural individuals. And what they found was that residents of those areas actually prioritized distinct features than those originally identified in the AFC. So as part of my work as a postdoc, we carried out a scoping review to really understand this issue in more detail and attempted to identify all of the existing audit tools that built off of the AFC, but then were applied to either rural areas or LMIC. And all in all, we found 7 other such tools, many with acronyms even longer than the AFC. So things like the Neighborhood Design Checklist, the MASB. But what I think is more important than looking at their individual components is what we can learn from examining them in detail in terms of best practices for developing indicators of this type. And we identified a number of best practices, including pilot testing. So that means whenever you're adapting a robust and widely applied tool like the AFC to a new environment, it's really important to see how the changes you make are actually perceived by the individuals who will be either collecting the data as researchers or responding to your surveys. The second best practice that we think is really important is triangulation. And this goes back to that original design of the AFC that includes both subjective and objective data. And then finally, this critical focus on the local context. For instance, in rural areas, people may be used to traveling longer distances. They may be more likely to have cars. And so something like having a public transit stop within 500 meters may either not be the right distance, or it may not be something that is actually important to healthy aging. And then finally, I think it's really important as researchers and people working in these areas to think about the ways in which embedding these practices can also provide a solid foundation for translating assessments into ongoing improvements. So just to take one example, if you develop a partnership with an organization that provides services to older adults to assist with pilot testing, you can maintain that partnership to carry out annual surveys to measure progress toward creating an age-friendly community. So that scoping review really led us to identify a need for developing a model that we could use within the context of the Prospective Urban and Rural Epidemiology study. So I'm going to tell you just a little bit more about the study. It's a longitudinal cohort study examining community, household, and individual behaviors and risk factors for cardiovascular disease. And it began enrolling participants between the ages of 35 and 70 from paired urban and rural communities, starting all the way back in 2003. And one feature of PURE that's really important for these analyses is that these communities were purposefully selected from high income, upper middle income, lower middle income, and low income countries in multiple regions of the world. And they were really chosen because they reflected this broad range of social, political, and economic contexts. So we wanted to take advantage of that really global capture and achieve 2 separate aims. So the first was to develop a robust and novel set of healthy aging indicators by integrating pre-existing environmental exposure data. And the second was to use those indicators then to describe systematic variation in the availability of healthy aging supports across Pure's broad and diverse sample of communities. We were also really interested in the extent to which there might be differences by country level income and community level urbanicity. So this study was actually published recently, but I did want to tell you a little bit more about some of the ways in which it worked. So we were fortunate enough that Pure actually had embedded triangulation into its environmental assessment collection. So we used two different tools that already existed within the context of Pure. The first tool is known as Epoch 1, and it relies on systematic social observation by trained local research team members who completed a checklist and carried out a 1-kilometer walk in each community center to assess 4 distinct environmental domains: tobacco, physical activity, food and alcohol, and social and economic. Epoch 2, the other tool that we use, actually applies an econometric approach to aggregate responses from a convenient sample of Pure study participants into a similar set of environmental scales at the community level. And each tool was actually carried out in a slightly different set of communities, but after combining them, we had close to 500 communities from 20 countries across 5 continents. And we use 2 different analytic approaches to really understand the relationship between our final set of 18 indicators and the AFC domains for which we had data available. We didn't have data available for all of them. But I'm just going to show the results of the multi-trait, multi-method approach here. I will quickly say that all of these analyses were conducted in R, and if anyone's interested in using these packages or kind of understanding how the analyses worked, feel free to contact me or ask in the chat. And I think what was probably the most interesting finding from this component of the analyses was the fact that the relationship among individual variables in terms of how they fit with the domains that we might think they would fall under based on the AFC criteria didn't necessarily conform to our expectations. So as you can see, there were actually a number of variables that had relatively weak correlations with the domain to which they would be assigned based on the AFC model. Just taking road quality as one example, it had a correlation of only 0.13 with outdoor spaces and buildings, the broader domain to which it would belong under that AFC framework, but actually moderate correlation with the domain of communication and information. More interestingly, perhaps, is when we looked at variation in scores by national income level. And I actually should say really quickly that one of the things that difference in how domains and indicators were assigned in the context of the AFC and what we saw from our analyses means that we perhaps need to look at specific indicators rather than broader domains or even a single age friendliness score. And as someone who's interested in research translation, this makes sense to me because I think it's much easier for local government to talk about how far most people are from a public transit stop than it is to say, we're hoping that our outdoor spaces and building score increases by an average of 1.2 over the next few years. But that really provides methodological evidence for that decision as well. So getting back to actually what we found when we applied those individual indicators across the 500 communities, perhaps unsurprisingly, we found that communities located in high income countries generally scored higher across the board, across all 18 of those indicators. But that wasn't true for every feature related to healthy aging. For instance, upper middle income countries, or UMIC, actually had the highest average scores when looking at two different forms of natural space: streetscape greenery, as recorded on that 1 kilometer walk, and access to a public park or recreational area. Somewhat surprisingly, low and middle income countries actually had lower rates of healthcare access than low income countries. And although low-income countries did have the lowest scores on many of the healthy aging supports, they were the most likely of any country income level to be connected to neighboring communities by regular bus service. There were also marked differences between urban and rural communities, and this was really highlighted by a few indicators that were only present in a very small proportion of rural communities. And that includes features such as traffic lights, with only 18% of rural communities in our global sample having them. The availability of train service. We saw very low rates of home internet, both in low-income countries and in rural areas. I should say, though, that these data were collected back in 2010, so that may be something that has changed in the intervening years. Interestingly enough, however, we did find, based on that econometric approach, where we actually surveyed participants themselves, that residents of rural communities reported a stronger sense of social cohesion, with an average score of 1.7 on a 4-level Likert scale, in which 1 is really that strongest sense of social cohesion. And that level of social cohesion is critically important, perhaps now more than ever. Now, I should say that this issue of a lack of social connections, the experience of social isolation and loneliness, affects more than just older adults. And obviously, it existed long before COVID-19. In fact, the United Kingdom even appointed a minister of loneliness in 2018, recognizing how important the issue was across that nation. But this long-standing challenge of maintaining social ties, particularly as we age, and especially in an increasingly urbanized world, was exacerbated for everyone by the physical distancing measures that were enacted to reduce the risks of COVID-19 transmission. And although this was true for everyone, it was particularly true for older adults due to their increased susceptibility to the worst outcomes of COVID-19. And in many countries, this increased vulnerability was actually built into the public health guidance that was developed around physical distancing. In the UK, for instance, vulnerable older adults were told to engage in shielding practices. That meant that their relationships with their friends, their family members, their neighbors were really even more fragmented than they were for everyone in the face of COVID-19. And unfortunately, this loss of vital social connections represents its own health threat. And that's because strong social ties have been linked both to better health behaviors among older adults, such as adequate fruit and vegetable intake, and also to significant reductions in the diseases of aging, including coronary heart disease and stroke. And social ties may be particularly critical for the cognitive functioning of older adults, because conditions such as dementia and depression increase the risk of social isolation. But this isolation in turn may exacerbate these conditions, increasing the negative symptoms that people experience. And this can really create a vicious cycle in which some of the conditions associated with age mean that people's social connections fray, they become more isolated, and then experience a worsening of their symptoms. Fortunately, we're learning more about other aspects of community design that may allow older adults to maintain their social relationships or even develop new ones. Now, much of these findings come from a systematic review that I'm currently working on with another group at the University of Sydney, the Matilda Center, that focuses on mental health. And our systematic review is really looking at what we know about connections between the built environment and social isolation and loneliness across all age groups. But I went back and looked to see what we know particularly for older adults. And perhaps intuitively, simply engaging in the types of activities that the World Health Organization defines as an indicator of an inclusive social environment. So that's something like weekly attendance at a religious service, participating in a weekly walking group, perhaps meeting a neighbor to play a game of chess once a week. So those regular activities can really help offset the shrinking of social support networks that's common in older age. And now some of that shrinking is due to the influences of conditions like I just described, but it's also unfortunately because that people often move into different settings in order to have a more supportive environment. And just due to the fact that as people age, they may lose friends to diseases of older age. But what we know is that we can offset that with social engagement. Now, where does such social engagement take place? Well, what we found was that older adults really value third places. So those are settings like community centers, the library pictured behind me, even malls in some instances. Essentially, third places are settings besides work or home. And one reason that this might be particularly important to older adults is that because many of them are no longer going into a workplace, that third place is really functioning as a second place. Another interesting aspect of environments that older adults themselves value is the chance to interact with younger people, or even sometimes simply be around them. And in fact, there's a fascinating piece of qualitative research conducted by a different team at SFU from here in Vancouver. They spoke with low-income older adults about their preferences for and interactions with blue space. So that's things like rivers, oceans, and lakes. And what they found was that one of the things they really valued about blue space was the chance even just to witness groups of young families, teenagers outside playing. So, that's not necessarily what we might think of when we talk about social participation or social engagement, but it's something that older adults themselves really value. It's also really important to remember that, like all old age groups, older adults aren't a monolith. And this is especially true when it comes to social participation. So for instance, there was a qualitative study in the UK that identified very gendered differences in the sites where older adults feel most comfortable. So many of the men that they spoke with stated that community centers didn't seem welcoming to them. And that was in part because they thought the types of activities that their local community centers offered weren't ones that were traditionally masculine activities. We also have some interesting insights into the way that place may influence preferences and needs for social participation from a study in Hamilton, Ontario region that actually focused on kind of this range of urbanicity. And what they found was that there were varying definitions of what it meant to be socially engaged in urban versus rural areas. The older adults that they spoke with in rural areas really talked about the quality of their social connections, whereas in urban areas, people were more interested in kind of the diversity of their social networks, so the number of people that they could call on for support. And then finally, as with age-friendly designs more broadly, I think it's really important to consider relationships among seemingly disparate features of communities. For instance, people may live within the standard walking distance. So we often talk about 15 minutes as a accessible walking distance to a third place like a community center. But barriers such as poor sidewalks or a lack of places to rest along the route may make that standard distance too far for many older adults and mean that we're incorrectly saying that they have access to a vital, healthy aging support when in fact they don't. So accounting for both individual preferences and differing abilities is vitally important as we begin to embrace models like the 15-minute city, which has much to recommend. So this concept of really having everything that you need for your daily life is being adopted around the world, but it's really taking off in Paris. And I firmly believe that age-friendly cities models can and should be integrated into visions like these, both as a matter of justice and to maximize the public health benefits of such a plan. But that means we need to think about who's pictured on the street and who may be left looking longingly down from a window. So just to kind of summarize some of the findings in this area of research. First, the age-friendly cities framework may not be applicable to all the settings around the globe. And when we adapt those indicators within a study such as PURE, we find that supports are generally less available in rural communities and low and middle income countries. We again saw that you really do need to adapt things to specific resource levels and contextual settings. We know that social isolation has a number of adverse effects on people's health, but we also know that there are things we can do to offset that loss of social ties, but that may look different for people residing in different areas and from different backgrounds. And then finally, I think what this shows is that no matter what a community looks like, it can support healthy aging in ways that both advance equity and improve overall public health. So I'm hoping that we have plenty of time left for a really interesting conversation, but I did want to quickly thank particularly the PURE research team members and study participants who carried out those 1 kilometer walks and contributed data to the EPOC2 tool, as well as my co-authors on that study. And I'm going to stop sharing so we can all see each other's faces and connect